Hello, everyone, and welcome to today's virtual presentation on evaluation and management of non-achalasia motility disorder. We'll be talking about medical and surgical approaches. My name is Michael Vaezi, and I am the clinical director and associate chief of the division here at Vanderbilt University. I am fortunate to be joined by two of my colleagues whom I will introduce, but before I do that, I just want to share with you the format of the webinar that we have today. As I said, we'll have two presentations followed by Q&A. I would like this to be interactive, and I hope that you'll be able to type in your questions. I will have the opportunity to look at them, and we will then ask the presenters. So please feel free to ask any questions that you might have about what you hear, or if you have questions regarding patients that you might have seen and how to manage those patients. So as I mentioned, we have two excellent speakers. Our first speaker is going to be Dr. Dan Patel, who's the assistant professor at Vanderbilt University Medical Center. Dan is an esophageal specialist at our Center for Esophageal Disorders, and his expertise lie in esophageal diseases like reflux, extraesophageal reflux, achalasia, and opioid-induced esophageal dysfunction. And that's the topic that he'll be talking with us today. Obviously, he's had numerous publications, edited two textbooks regarding management of dysphagia and obesity and esophageal disorders. And he is well established in several high-profile national journals by publications in gastroenterology, CGH, clinical gastroenterology and hepatology, and is well connected with the AGA as well as the International Foundation for GI Disorders and the Society for Diseases of the Esophagus. So we're really pleased that he can join us and tell us and give us his expertise on the impact of opioids on esophageal dysfunction. And as you know, this is a welcome topic given the increasing use of opioids and how that might impact our patients and their presentation. Dan, welcome.
Well, thank you very much, Dr. Vaezi, for that introduction, and ISDE for setting up this webinar. So my topic is going to be opioid-induced esophageal dysfunction. This is a very new entity, but it might have sweeping consequences. So I think it's a great topic for today's webinar. There are no disclosures that I have relevant to this presentation. As we all know that we are in the midst of an opioid crisis. There are about 130 Americans that die every day from an opioid overdose. And this is obviously including both prescription opioids as well as illicit opioids. So if you look at kind of CDC statistics, opioids are used for non-cancer related chronic pain in about 4% of the US population. So they're quite widely used. Now, us as GI providers have learned about the effects of opioids on GI tract in multiple areas. The most common ones that we know about are, of course, gastroparesis, because it causes delayed emptying. And these effects of the stomach are present in anywhere from 42 to 48% of people that are on opioids. We also very well know the effects of opioids on the colon, and we know opioid-induced constipation is present in about 40 to 60% of patients using opioids. But what's going to be of interest to us is, because we know the effects of opioids on stomach and colon, we've started to understand that there also might be an effect on the esophagus, and whether it causes disorders of peristalsis or hypertonic LES. So that's going to be the focus for today. Now, when we look at how opioids might affect our gut, really it comes down to the opioid receptors. So we have mu, delta, and kappa receptors, as shown here in our GI tract. And obviously we have both endogenous opioid peptide and exogenous, which are medications that we use. These can lead to a decrease in cyclic AMP in our nerve targets and lead to blockage of calcium channels and lead to inhibition of the neuronal activity and neurotransmitter release. Now, this has a variable effect depending on the area of our gut. So if we talk about esophagus, There are animal model studies that show that it tends to increase the tone of the lower esophageal sphincter and decrease the relaxation. And it also tends to generate high amplitude simultaneous contractions because it takes away the inhibitory neurons of the esophagus. When we talk about stomach, it tends to kind of increase the pyloric tone and decrease gastric emptying. And then when we talk about duodenum, it tends to kind of increase tonic contractions and decrease propulsive action. So when we talk about the esophagus, as we know about normal peristalsis, it's really driven by inhibitory neurons. And we have this diagnostic latency that when a bolus is propagated through the esophagus, it's this sequential relaxation of the distal esophagus that leads to this nice peristaltic motion from use of nitric oxide and VIP. So we propose that obviously the mechanism in opioid-induced esophageal dysfunction is this inhibition of release of nitric oxide and VIP, and that takes away this latency gradient in the esophageal body. So now you don't have the sequential relaxation, and this leads to this simultaneous high amplitude contractions in the esophageal body. And so this first came about where there was a study that looked at studying patients on opioids versus off opioids for 24 hours. And they found that patients that were on opioids were much more likely to have EGJ outflow obstruction on manometry, so 27% versus 7% that were not. And they were much more likely to have a type 3 achalasia pattern, 11% versus 0%. So this really was one of the pioneer studies that raised the concern about the effects of opioids and esophageal motility. Now, subsequently, we also found that while in chronic opioid users, you can also see other spastic disorders. So obviously, we talked about EGJ outflow and type 3 achalasia, but you can also see things like jackhammer esophagus and distal esophageal spasm. And so there was a study done that looked at a long cohort of opioid naive versus chronic users on 224 patients. And they found that approximately 10% of patients that are referred for manometry were on chronic opioids. And more importantly, when you look at the symptoms here, patients that were on chronic daily opioids were much more likely to complain of dysphagia. You can see nearly 2 out of 3 patients on chronic opioids had main complaint of dysphagia that were undergoing motility study. And when you look at the type of motility disorders, really what stands out is patients that were on chronic opioids were much more likely to have a type 3 achalasia pattern, so 13% compared to 1, EGJ outflow obstruction, and distal esophageal spasm in this large cohort study. We also looked at our cohort, which nearly had 1,000 patients that were on chronic opioids that had undergone a manometry, and nearly 4,000 that were opioid naive. And clearly, again, what stood out is a lot of patients on opiates do tend to have dysphagia that are undergoing manometry. But in our study, we didn't necessarily see a correlation with type 3 achalasia or outflow obstruction, but the main findings were spastic disorders of esophageal body, where we saw much higher incidence of jackhammer and distal esophageal spasm on people with chronic opioid exposure. And if you look at the specific metrics like distal contractile integral, you look at the mean wave amplitude and the basal lower esophageal sphincter pressure, you clearly see that patients that are on chronic opioids do tend to have higher DCI, they tend to have higher basal LES pressure, and higher in IRP compared to opioid naive patients. So we know that it does affect these metrics. Now, there was also a very interesting study that recently came out from Dave Katzka's group that looked at what about acute versus chronic opioid exposure. So they looked at patients who were getting opioids because of moderate sedation during endoscopy. And if you do a manometry study, after that endoscopy, so they looked at whether less than 240 minutes compared to 240 to 480 minutes. And they basically found that acute opioid exposure doesn't tend to lead to any abnormalities in esophageal motility parameters like DCI, distal latency, or IRP, or resting lower esophageal sphincter pressure. So this brought up the question that it might not really be an acute exposure issue, but it might be a chronic patients that are on long-term opioids that might lead to changes in esophageal body metrics. And potentially there is a correlation with also a dose of opioids they're on, where in this study, of course, if you look at the morphine equivalents of opioid dose that they were on, people with type 3 achalasia had higher opioid dose compared to EGG outflow, spasm, or jackhammer esophagus. So dose might also play an important role. As well as the type of opioid. So when you look at full mu agonists, things like oxycodone, hydrocodone, they tend to have much more higher prevalence of motility abnormalities compared to partial agonists like tramadol. And really, when you look at studies, partial agonists like tramadol are not really associated with spastic disorders compared to full agonists. So this also might be an important point to keep in mind when we're managing these patients. Now, when we talk about clinical presentation of, well, how do people with opioid-induced esophageal dysfunction present, and are there clinical clues that might help you differentiate the two? Really, there aren't. So clinical symptoms alone are insufficient, of course, for diagnosis of opioid-induced esophageal dysfunction, because they'll present with similar to any other motility abnormalities with dysphagia, solids, liquids, regurgitation, or atypical chest pain. And when you do a diagnostic evaluation on this patient, they might, of course, look similar to hypertonic LES and achalasia with the pucker GE junction. And so it's hard to distinguish an endoscopy by itself. Now, when we talk about manometry, of course, we talked about the patterns that are associated with opioid use in terms of type 3 achalasia, outflow obstruction, jackhammer, or spasm. And it's hard to know, well, are those idiopathic or are they truly a medication effect? So one of the ways, one of the studies that tried to characterize, well, are there provocative maneuvers that might help you identify someone that's idiopathic achalasia, which you see on the left side, versus an opioid-induced achalasia, which is on the right side. And they use two maneuvers. One is called amyl nitrate, which is, of course, relaxes the esophageal muscle. And if you do inhaled amyl nitrate in someone that has idiopathic achalasia, because they have this massive excitatory input, you'll see this transient relaxation of the lower esophageal sphincter, followed by a very high rebound contraction. And you don't see that in someone with opioid-induced achalasia. And the reason behind is their inhibitory system, which is out in idiopathic achalasia, is not irreversibly out in someone with opioid achalasia because it's a drug effect. So this might help you potentially differentiate whether it's a drug effect versus idiopathic. The same thing with cholecystokinin. If you do an injection, you do see this massive rebound contraction in someone with idiopathic achalasia compared to someone that has opioid-induced achalasia. So these are kind of two maneuvers that could potentially help you differentiate, but they're not as widely available, and they're only done in very few centers across the US. So that is a little bit hard to implement in real clinical practice. There was also a study that looked at multiple rapid swallows and whether or not someone with opioid might have impaired inhibition. And on the left, you see clearly a normal response where you have multiple rapid swallows followed by a nice peristaltic esophageal contraction. And someone with opioids, because of inhibition of that latency period in the esophageal body, you tend to see that despite multiple rapid swallows, they don't have complete inhibition of the esophageal body, and that might be a clue. And they found that people that were chronic opioid users were much more likely, more than 50%, to have this impaired inhibition response in multiple rapid swallows compared to non-opioid users. And so really the diagnostic evaluation for these patients comes down to is if you see these patterns of spastic disorders on manometry, of course, do a thorough medication reconciliation. If they're on opioids, and if it's safe, consider repeating the manometry off of opioids to see if those patterns resolve. And this was primarily based on this one study, which showed that a patient that might have EGD outflow obstruction, if you did a manometry off of opioids, some of the patients might normalize completely. And so if safe to do, doing a manometry off of opioids to see if the manometric abnormalities resolve is very reasonable. And if you're not able to do that, and of course the question comes about is how do you manage this patient population? really there is a very lack of data on use of opioid antagonists, things like methyl naltrexone. This is a hot area of research. But really the first line again is withdrawal of opioids, because we think this might be a reversible medication effect on esophageal motility. Now, if that's not an option, see if you might be able to switch them to a partial agonist instead of a full agonist, particularly because partial agonists so far have not been associated with spastic disorders. And then, of course, you can try empiric esophageal dilation to see if their dysphagia symptoms improve. Now, here is a question, well, if you tried those conservative measures, and if they're still having persistent symptoms and you can't really withdraw opioid or switch opioids, as a lot of patients are not able to, here's a polling question for you guys. What would you offer next? Would you consider doing a pneumatic dilation in someone with a spastic disorder related to opioids, myotomy, or do you think Botox might be a better option as the next step? So I'm going to launch this poll for you guys, and you should be able to see it on your screen. And I'll give you guys kind of 20 seconds to see where most of the people offer in this situation. So this is great. Looks like a majority of you of the pollers are offering Botox injection as the next option. And there is about a quarter of you that offer pneumatic dilation or myotomy. And so that is excellent. And so really for us, we believe that because this is a reversible effect of opioids potentially on the esophagus, we do think that Botox and staying conservative is better in this situation. And so Botox, of course, the method here is you inject 25 units of Botox into 4 quadrants of the LES in people with type 3 achalasia or EGJ outflow. And the reason it works is, of course, it blocks the acetylcholine release and the excitatory pathway, resulting in relaxation of the smooth muscle. And this is fairly well tolerated in studies, of course, based on achalasia studies. The side effects are maybe very low in terms of transient chest pain or reflux symptoms, but overall fairly well tolerated in clinical practice. So if the patient doesn't respond to Botox injection, and if they truly, of course, have a type 3 achalasia or outflow pattern, really what we want to do is make sure that they truly have a significant issue with barium emptying. And so we suggest getting a time barium esophagram, look at the esophageal emptying at 1, 2, and 5 minutes. If they have a significant delay in esophageal emptying, then that would be consistent with issue with outflow obstruction. And in this group of patients, you might consider pneumatic dilation or myotomy if there is significant retention of barium in the esophagram. However, we do have to proceed with a lot of caution here because this potentially is a reversible effect of opioids, and you have to discuss risk and benefits with the patient and respond to any therapy. Of course, it would not be optimal if pain is the chief complaint. So there's only been really one small study of 5 patients with opioid-induced esophageal dysfunction, where 3 had achalasia, 2 had EGD outflow obstruction. They did pneumatic dilation, and they had very little improvement in symptoms. So, of course, a very small case series. But the way we differentiate here is if the chief complaint that the patient has is atypical chest pain, certainly dilation, myotomy are unlikely to be helpful in that situation. But if dysphagia is the predominant symptom and they have type 3 achalasia with significant retention of barium, then you might potentially consider it. But you have to kind of talk about risk and benefits and telling them, of course, that if you don't stop the opioids, even doing a myotomy might not potentially resolve your symptoms. So that's all I had for today. And thank you very much again for inviting me to give this talk.
Great. Thank you, Dan. A few questions, if I could ask you. That was really well done. So you said that the studies that you did found that you're finding more spasm and jackhammer esophagus rather than achalasia. Now, on the Botox injection, would you then, you may have said this, would you inject it similar to achalasia treatment, or would you do it up and down the esophagus? Can you be more specific on like what dose you put in the LES, what dose in the esophagus, if the finding is spasm or jackhammer?
Yeah, I think that's an excellent question. So for spasm and jackhammer, we do have to address the spastic contraction of the esophageal body. So there has been, of course, only one RCT of Botox injection in those patient population. And really the pattern of injection is you do inject about 40 units out of 100 into the LES and then inject 10 units, so a cc, every centimeter away from the LES in the distal esophageal body to address that distal spastic contractions. You do have to be careful not to go too far away from the LES. We try to avoid going proximal to 30 centimeter because then you might inject into skeletal muscle and lead to potentially more symptoms. So yes, in spasm and jackhammer, inject at the LES and distal esophagus.
Yeah, that's good. So another question, which I think is actually interesting, you mentioned if you can stop the opioids before high resolution manometry. One question that was really good that came to us was how long before the high resolution manometry would you stop it so that the impact of opioid you would feel comfortable is not there? A week, 10 days? How long do you do that?
Yeah, I think that is also an excellent question. We don't quite know the answer to that yet. We do know that obviously acute exposure doesn't lead to effects on motility. But I think it partly depends on the half-life of the opioid they're on in terms of like a fentanyl patch versus long-acting morphine. But ideally, I think 2 days or longer is better than just 24 hours for opioids
Yeah.
to make sure that they're gone. But I think it's a good area for research.
Yeah, the flip side of that is how long of an opioid exposure does it take for one to actually get some of the findings that you and others have shown, which is the hypercontractile state. So if I take, I have dental procedure, I take opioids for a few days, is that going to put me at risk? Or what is chronic versus acute, I guess is the question. Yeah.
I think that is exactly correct. And we do have to be mindful of, obviously these studies, they're done on people that were referred to a manometry procedure because they were having symptoms. So we don't know yet what is the gross prevalence of dysphagia symptoms in everyone taking opioids, right? This is a specific subset of population that is symptomatic. And of course, a lot of them are referred for a study. So I think that's also an important thing to study.
Yeah, I agree. I mean, these are the tough areas that we struggle with clinically, right? So what to do for some of these. There was an interesting question that just came through and it says, well, if you can't stop the opioids, which in many of our cases we can't, you even need to do the high resolution manometry, knowing there may be an impact of the opioids. So would you argue not to do that and do something different, i.e. endoscopy or barium swallow, or would you still do it so that you at least have a diagnosis?
Yeah, no, I think I agree with the pursuing manometric evaluation. And the reason is it does have a good negative value, right? So most people that are on opioids are not going to have an spastic disorder in the esophagus. Most are going to have a normal manometry. And so I think if you find a normal manometry, then that is very reassuring. Now, of course, if you find a spastic disorder, which again, it's rare, then you might correlate it with, but that's the reason to do it is I think it's good negative value.
Yeah, yeah, I agree. Now, if I can't, so let's say you did Botox, Dan, and it didn't help, and patients, let's say, have more of a spasm or type 3 achalasia look. You said you do Botox first. Then at that point, do you do pneumatic dilation? You said that yes, but with caution, you let the patient know. And pain, that's an important factor. If pain is the driver, you would not recommend it. Is that right?
Yeah, that is exactly correct. I think I let it drive based on the major symptom that the patient has. We know that majority of the, if patient's primary complaint is pain, that does not get better even with Botox. So even in the RCT, where they looked at Botox and spastic disorders, dysphagia gets better, but pain does not. So I think if chest pain is the predominant symptom and they're not having any dysphagia, you really have to look at neuromodulators as your first step if they're not able to come off instead of doing an invasive procedure.
Yeah. So there's a question about gastric emptying. Clearly, esophagus is kind of interesting because it gives you this hypercontractile state due to opioids. But in the stomach and the colon, it's sort of a hypocontractile state, right? So in someone that may have symptoms, upper gut symptom, do you recommend them getting gastric emptying study as well? And at what point do you suggest that? Yeah.
Yeah, I think if their main symptom is regurgitation and kind of refractory regurgitation, then I think gastric emptying study is helpful. And again, obviously there's going to be a huge number of people that might have a positive study because they're on opioids, right? But it's the negative study that might potentially help if you were looking at a normal emptying. So I think it is helpful if regurgitation is a primary complaint.
Yeah. There's this one last question about role of cognitive behavior in functional disorders. So the reason this is important is because, you know, instead of giving all these opioids or neuromodulators, should we really be focusing on cognitive behavioral therapy where you would avoid some of the issues that you've been discussing?
Yeah, no, I think that is an excellent topic. I think we're starting to understand more about the brain esophageal axis and how anxiety and hypervigilance might play a huge role in symptomatology, even in people that have organic disorders, right? So things like EOE and GERD. So I think cognitive behavioral therapy in someone that has a lot of anxiety is always very helpful, but it's not widely available. So I think that's the issue is there's not a lot of psychogastroenterologists available at most centers.
Yeah, no, I agree. I said that was the last one, but this is actually a good question that I also had is if you can't switch them to partial agonists or less aggressive. So is the motility disorder that the patient now has due to chronic opioid use, is it permanent? In other words, how does one know if you switch them to partial agonists or you're able to discontinue, would the effect go away? And in what percent do we know that?
Yeah, we don't quite know what percent, but we do think it's reversible, partly because there are studies that show if you take them off opioids, the motility abnormalities resolve. And there are studies looking at those provocative maneuvers that I talked about with amyl nitrate and cholecystokinin, where you clearly see that their inhibitory pathways are active, but they're just being reversibly blocked. So I think that the disorders aren't necessarily lifelong, but I think it depends on how long they can stay off of opioids.
Great. Thank you so much, Dan. Excellent presentation, and I appreciate your answers to some of those important clinical questions.